So we're now going to go over the insertion of a 5 French Swan-Ganz pacing catheter. We already have a 6 French cordis in place in this patient's right IJ. And so the important thing is that it is very important to drape very large in these types of patients, because these are the highest risk patients for infection. Many of these patients will go on to permanent pacemakers, and there's a higher risk of increased morbidity and mortality if the permanent pacemaker gets infected. As you can see on your table on the right-hand side, you have the 5 French pacing Swan-Ganz catheter. Swan-Ganz just means that it is a balloon-directed catheter that can be put in without fluoroscopy in order to get the balloon into the right place. Next to it, you'll see that there's a syringe that is used for testing and opening and closing the balloon. And next to that, there is the actual sheath that covers the whole pacing catheter to keep the area sterile so that it can be redirected later on with gloves off. So what we're going to do first is we're going to set up in order to do pacing. In order to do that, we need to, number one, give the back end of the catheter to our assistant. And so I'd like you to give the back end of the catheter to the assistant. And you're going to keep the sterile side. You can also pass the syringe to the assistant. And before we move on to the assistant, we're going to put the sheath that covers the actual pacing catheter on. This is one of the commonest areas of error. We often will put the sheath in the wrong direction. Whenever you are thinking about the correct direction to put it on, the actual sheath cap needs to come to the same side as the cap on the cordis, and therefore it's very important to put it in the correct direction. And so yes, that would be the correct direction. Push it all the way in and put the sheath all the way towards the hub, because that can be inserted later. Excellent. Now we're going to move over to our assistant, and we need to make sure that we're prepared to actually do the insertion. The first thing we will do is a balloon check. So if you can please insert approximately 1 cc of air into that balloon. You will need to also uncap so that it is open to the actual catheter. Perfect. And then we're going to look to see, and our balloon expands appropriately so we do not have a ruptured balloon. We can now put the balloon down. You will, when actually inserting the catheter, you will be directing once you're in the opening and closing of the balloon in order to go with blood flow. Now what we have to do is we have to set up for pacing, and so your assistant will first take the 2 red colored adapters, which need to be attached to the black end as such. Perfect. And then after that, we will need to have a pacing box that is already set up. This is a dual pacing box. In other words, it can do both arterial and venous pacing. In this case, we're only putting a single lead in, therefore we will only use the venous side of the pacing. We have the actual electrical connector that goes to this end of the pacing catheter, and so it will be plus to positive. Which we will connect. And so as you push the adapter in, you need to turn the red knob in order to tighten it and ensure that it appropriately secures. So we'll do that for both. And so for the negative, the other side will go in, and then you tighten the black and make sure that it does not fall out. Excellent. Next, we need to prepare for pacing. So again, when we go in, we will want to be pacing so that we can watch on our monitor. So in this case, you will want to select a fixed mode of pacing, so typically a VOO mode of pacing, which can be done on the box at a rate that is higher than the intrinsic rate of the patient. So in this case, let us use maybe 80 beats per minute. I also typically suggest that the output be increased to the maximum because you want to be able to capture the heart. So most of these pacers will go up to approximately an output of 25 millivolts. So again, in VOO mode at 25 millivolts of output. And so now there's electrical energy that is coming off of the tip of the pacing catheter. And so we will just confirm that. And exactly, we're at 80 beats per minute at 25 millivolts. Because we're in a VOO mode, the V means the chamber that is paced. O, the second letter, means the chamber sensed. So with O, we're not sensing at all. And the last letter tells us what happens if you sense something in that chamber. In this case, we're not going to do anything if we sense something. In other words, this is fixed pacing. It will pace through whatever intrinsic rhythm the patient has. Now we will go over the insertion of the actual balloon. So the primary operator will start by inserting the catheter, it is important that the catheter's angle is towards the right atrium and then curving towards the right ventricle. So in this fashion, you would want the curve to be in the same direction of where the heart would be, as you've appropriately done. And so we will put the catheter in from the back end. As you had appropriately done, you had removed the blue initial connector that was there to maintain sterility. So this catheter will slowly be pushed in, and you will want it to go to at least the 15 centimeter hash mark point. There are hash marks on the catheter that tell you every 10 centimeters. Once you get to approximately 15 centimeters, you're beyond the distal point of the sheath, and therefore, once you're there, you can ask your assistant to expand the balloon. Whenever you open and close balloons in arteries or veins, make sure to never expand them against pressure. If you feel any resistance, you should stop. So with no resistance, if you can expand the balloon.
Balloon up.
Balloon up, thank you. So with the balloon up, the catheter will now follow the direction of blood flow. As you know, you're in the right IJ, which will then go into the SVC and then into the right atrium, with the goal being of getting this catheter into the right ventricle, ideally the right ventricular apex. So I'd like you to slowly advance. Typically, you will hit the RV at around 30 to 35 centimeters. Obviously, patient height, size, so on and so forth matters. While you're doing this, you're going to be watching your monitor. This patient is currently in 3rd degree heart block. You're going to be watching your monitor to look for a change in rhythm to when you have ventricular pacing. When you see ventricular pacing, you will have a wide, complex ventricular-only rhythm at 80 beats per minute that suggests that you have captured the heart. So continue going down until you are able to get capture on the monitor. So as you can see, after we have inserted typically to a depth between 30 to 40 centimeters, you will see a change in the rhythm from 3rd degree heart block to ventricular pacing at 80 beats per minute. You know that there is ventricular pacing for 2 reasons. Number one, there's a sharp spike that is produced by the actual pacemaker, which is detected by the monitor, as well as the wide, complex rhythm, typically in a left bundle branch block pattern, that is suggestive of ventricular pacing. So we are now in the appropriate position. What we're going to do is to ensure that there's stability at this position with balloon down. So you'll ask your assistant to put the balloon down. And as you can see, the pacing continues, so the catheter's tip has not moved. Once we do this, we're going to secure the position of the catheter. The way that you're going to do that is by moving the sheath all the way to the actual cordis. There's a little locking mechanism on it that attaches to the cordis. So I'll get you to first lock that. And once you do that, you can extend the length of that sheath to give you more room to play with the catheter for sterility purposes. So yes, excellent. So now we have space in order to manipulate the catheter. So we now are going to do a threshold test. The way that we're going to do a threshold test is that we are going to slowly reduce the millivolt output of the pacemaker to see what is the lowest voltage at which we will see capture. So the first thing to do is to unlock the box, as your assistant has already done, and then we will reduce by 1 knob, or in other words 1 millivolt. Typically, the practical way of appropriately doing this is to watch for at least 3 beats prior to going down another millivolt. We'll do the first part a little bit fast because we're at 25 millivolts. So in this case, as we're watching the monitor, we can see continuous pacing occurring. And so we're already down to 14 millivolts and we have continuous pacing. A very good threshold is typically 0.1, 0.2 millivolts. And so in this case, let's see how far down we can go before hitting it. So we're at 5 millivolts. So now once we're at 5, let's go a little bit slower. So 4 millivolts, we can see there's continuous pacing for 3 beats. Let's go down. 3 millivolts, 2 millivolts, 1 millivolt. Perfect. And so we still see continuous pacing. So that means that the threshold is at least 1. Let's keep going down. So as you can see, at 0.8 millivolts, we lost capture. In other words, we're back in 3rd degree heart block. That means that 1 millivolt was the last level where we got complete capture. So at 1 millivolt, this is considered a threshold. For safety reasons, you will want to be at least 3 times the threshold. Because these pacemakers are external pacemakers, we can change the boundary. Safety even at 5 millivolts would be reasonable. We will want to have some safety margin. The typical safety margin is at least 3 times threshold. So we'll increase to a minimum of 3 millivolts. In external pacemakers, it is not as important to keep the threshold, the output low, because you're not trying to save an internal battery. So for safety, you could even go up to 5 times threshold. So I would leave this pacemaker at 5 millivolts. It is important to do a threshold test daily. If the threshold suddenly changes, it would be one way of determining that your catheter has moved, and then you can hopefully reposition it prior to the risk of the patient having an asystolic event or having a sudden change in rhythm. Obviously, once you have one of these pacemakers in, it is important, if you are going towards permanent pacing, that it is done quickly, because the risk of infection is very high with transvenous pacemakers, and so you would want definitive therapy as soon as possible through cardiology consultation. Thank you very much.